Hello and warmly welcome to our summaries for early breast cancer from ESMO Congress 2023. I'm really honored to be here today with Professor Christian Jakisch, who is head of Department of Gynecology and Obstetric at Academic Hospital Sana Klinikum in Offenbach. His main focus is in clinical research of gynecology and gynecologic oncology, as well as breast cancer. In this context, he is mainly focused on the endocrine regulation of breast cancer and the therapeutic impact of the new treatment options. I'm really honored to be here with you today, Christian, and just briefly about myself. I'm Tanja Španić. I'm the president of Europa, Donna Breast Cancer Association in Slovenia, and I'm also the chair of ESMO Patient Advocates Working Group. Christian, please lead us through the abstracts that we picked for today.
Yeah, thank you so much, Tanja, for the nice introduction. First of all, as usual, we just enjoy our disclosures, which are not in any competition with the contents what we did. So I fully agree with you, Tanja, that the ESMO this year's was fully loaded with new informations, which are mainly focused on daily patient care. And the pleasure on my end is that we are discussing this with you from a global perspective on Europa, Donna, and me as a clinician working every day at the bedside. So as you know, the gynecologists in Germany are just working on cancer and on obstetrician as well. And the link in between these two heads is actually the preservation of fertility in oncology treatment. And this is why I picked this abstract as number one, because for me as a gynecologist, oncologist, and an obstetrician, it is very important that we deliver our patients, even if the diagnosis of breast cancer is done, a knowledge and the perception of fertility risk and fertility preservation. So in other words, I think we should discuss it at the very first beginning when we discuss cancer treatment. And the background of this information here is the question, what do patients know about this? And what Dr. Naimi did here was a questionnaire to ask her patients about their upfront knowledge about this issue, because I think the most important information we received from Ann Patridge that has been published is the positive trial that you can interrupt endocrine adjuvant treatment to get pregnant. And on that basis, this was just eyeballed by me. And this was a number of patients younger than 45 years of age. And you can read it by yourself, the personal experience and the knowledge about this very important topic before you set these patients on chemotherapy or endocrine treatment. And I just highlighted the most important information from my end, but Tanja, it would be very interesting to see what your take home of this is. The level of information about risk related to breast cancer treatment and the level of informed patients. And you're going to see that 55% of those young women, 45 years of age and younger, had only a level of information or have been informed about the options we all have. And if you just go down on this table, you're going to see some of the ideas of artificial reproduction, like freezing eggs available in the future and other issues. I don't want to deep dive into that, but I think it's an important situation, what I assume is going around in Europe, that people are not fully informed about this issue when they are just faced with the treatment of early breast cancer. So my take home here, and I would love to discuss it with you, is that this is an urgent need to take action into routine therapy in early breast cancer in our guidelines and in the AGO recommendations for the diagnostic treatment and follow-up of breast cancer. It's an obligatory measure to inform those patients and to partner with the fertility center in your suburbs.
Thank you, Christian, for this really nice overview. I totally agree with you. We've done something very similar, but on a smaller case within the BCY, Breast Cancer in Young Women Conference. And we also saw pretty much the same results. What is the main thing here? I was diagnosed very young. I was diagnosed when I was 26. So I have also a little bit of personal perspective in this. The thing is that when you are diagnosed, you don't have time or even capacity in your mind to think about this. And also doctors should inform younger women about these options, about fertility. And now, since you mentioned already, since we have even the results from the positive trial, this is even more important. Now we know how that even stopping the endocrine therapy is safe. So this would have to be improved on both sides, information for the patients and of course for the doctors to have these options. But unfortunately in Europe, still around Europe, access to fertility preservation is still not available widely. And in many countries, it's still paid out of pocket, which is also why we need a lot of data, a lot of enough clinical research that we can support this, and this could be also part of our health systems. I don't know how it is in Germany. How many experiences do you have with fertility preservation?
So we have, thank you for playing back the ball in my part. It is an option. So we have federal regulations on that. And it is mostly the consultation is free, and most of the costs are covered by the sickness funds in specific regulation. Interestingly enough, it's only for hormone receptor positive breast cancer. So this is the typical regulation era. You would go for triple negatives as well, but at present, it is only covered for hormone receptor sensitive breast cancer. So we're going to see even here is much room of improvement.
Yes, yes.
Okay, let's walk on.
Thank you.
The next one is also an issue about information. So we are switching to HER2 positive, classical HER2 positive adjuvant breast cancer. And we all know, and this is something I picked because it's about patients' communication. So we all know that the line of treatment in HER2 positive breast cancer is going from neoadjuvant to post-neoadjuvant or adjuvant treatment, and even to the extended adjuvant treatment. So it's a question about the correct definitions. And even that we are in the position that we just optimize the outcome of HER2 positive breast cancer, there's still a risk of recurrence in this disease, even after pathologic complete response. And we all know that there are various mode of actions of different drugs, the classical antibodies, and here neratinib is a pan-tyrosine kinase inhibitor. It's an oral available drug that can be used in those patients with increased risk of recurrence after neoadjuvant and or adjuvant treatment of early breast cancer. And the NERA study has been performed to see what are the patient's profile, or in other words, what is the communication level to let patients know that you could use this drug in your country, given the fact it's available and reimbursed, to minimize your treatment outcome, optimize your treatment outcome. So the basis of this is the EFFICAcy trial, which is delivering really good basis and information of this. And the authors about Dr. Laurentius were just asking the question, who actually are those patients? And I was just cutting out of the poster this very nice overview about the various combinations of anti-HER2 treatment. And you're going to see that the majority of those patients received trastuzumab only. Some of them received TDM1 in light purple and in dark purple, the combination of the dual blockade of trastuzumab and pertuzumab. So in other words, the trastuzumab only treatment option, which is around the globe about 80 and 90%, are actually those patients who are captured by the EFFICAcy trial. Because even whatever it happens, if you are hormone receptor positive and HER2 positive in your disease, then you're a candidate for an extended use of this oral drug. Given we are not discussing here the side effects, I don't want to talk this drug down, but it's just an option to fight recurrence. And these are data from Croatia, France, Belgium, Spain, and Italy. So it's a very nice snapshot of what's happening in Europe. And these are in the majority, those patients being at risk, premenopausal women. The median age was 48 years. And you're going to see here, it's small tumors. It is 2/3 of those patients at nodal involvement. So they're of increased risk of recurrence. And then you're going to see that 60% of those patients receive trastuzumab and pertuzumab in their neoadjuvant setting, and 31% trastuzumab only. So the amount of PCR was only 19%, a very small number actually, as far as I'm concerned. And if you have the data from the ExteNet in your mind, you know that just in specific, those patients with a non-PCR, and these are here more than 80%, obviously, might benefit from this. So again, what I'm saying here is, or advocate here, is that the full load of information should be presented to our patients at the beginning of the treatment. So Ms. Miller, for example, this is treatment option neoadjuvant. That would be adjuvant. And now we have the options of post-neoadjuvant. What I would like to avoid is that you're just giving something, and then when you are just hoping you can escape that, so then the next information is coming in, and then when you just have the idea, okay, my treatment is finished, and then the doctor is just making a comment, we have still another one, and then you're asking yourself, when does this treatment stop? You know, and that's something where I'm so happy, Tanja, that you are with us to let us know what you would give us as an advice from your perspective.
Thank you, Christian. This is really a nice overview and really nice example how communication and having access to all information is really important. Here, I would say that the most important thing is that let's say you inform patient step by step, because at the beginning we saw with the neoadjuvant, with the treatment before the surgery, what patient can receive and what happens afterwards. And as you said, you can say the treatment is finished, but you have another option. And I would say that most of the patients are afraid of recurrence and later recurrences in the early setting of the disease. And this is very important that we have additional options to lower this, let's say, chance to get the disease again. And that's where this communication comes even more important. Even if as a beginner, at the beginning, as a patient, you cannot be aware of all the information and all the options, but this is why it's very good example with neoadjuvant treatment, when we start with the treatment before the surgery, and then we have surgery and so on. This is a very good cancer patient journey when we can get additional information, and especially if the treatment is available for patients in that country.
Right. Yeah. So I think we're sitting in the same boat, rowing to improving the evidence for those patients, and the information that should be delivered ahead of time, that the patient and the families have some time to really reflect if that's something what they would love to use. Now we're coming to a very hot topic, and that is something what the yellow press is just eating up very speedy. That is the rumor that if you have a whatever after neoadjuvant treatment, you have a pathologic complete response or an imaging guided pathologic complete response, that you could omit breast cancer surgery after neoadjuvant chemotherapy. And anytime I read these data, I just caution our patients to do it, because this is far away from being prime time. Regardless of this, Dr. Cura from the US is a pioneer of doing this. And if you recall it, I think it was San Antonio 2 years ago or 3 years ago, there was a whole oral session on this topic, and the evidence was far away of agreeing to do this. But let's deep dive into these data, because maybe in some time that might be an option. So the rationale behind that is that after neoadjuvant chemotherapy for triple-negative breast cancer and HER2-positive early breast cancer, which are the candidates for neoadjuvant treatment, the pathologic complete response is occurring in about 60% of our patients. So we know that a PCR is just predicting an excellent prognosis, but it's not saying or giving you a guarantee that there's no relapse. So we have to divide distant relapse and the intra-breast or the breast recurrence on the affected site. So what these guys did in this phase 2 trial was actually to see if there is in 3 years end or duration after the neoadjuvant therapy with the question, is there a pathologic or maybe an imaging guided complete response? They provided after the neoadjuvant therapy vacuum assisted core needle biopsy, and then if they were negative, they didn't do any surgery and would just following up those patients. And there is a proof of concept. You see the references, Lancet Oncology of 2022. There is the two years follow-up data, and now we're going to see the update. So these were 50 patients only, and then you're going to see that there was no invasive core needle biopsy after the neoadjuvant chemotherapy, and they went to radiation of the whole breast instead of breast surgery. And the primary endpoint was ipsilateral breast tumor recurrence and scientific translational research program on circulating tumor cells, which is an ongoing hot topic. So what they found, median age was 6 years, and you're going to see triple negative and HER2 positive disease. And the pathologic complete response after vacuum-assisted core needle biopsy was in 31 patients, 62% of their new definition. And they had a follow-up of almost 40 months, and the 3 years disease-free survival and overall survival rate was just 100%. So you cannot do it better, but I think that is a pre-selected cohort of patients, just showing that it's worked. So I think the problem here is if you don't read the abstract, if you don't see the full paper, you just get the wrong message if you translate that in your everyday procedure. So my follow-up is promising, needs further follow-up, longer follow-up, and it's a pre-selected group of patients. And, you know, after more than 34 years working into breast cancer, I think the pathologic complete response needs surgery that the pathologist can nominate it as pathologic complete response, and that's a standard of care. And it's not ready for prime time from my end. Tanja, what is your thoughts on that?
Well, I was really happy when I saw that you picked this abstract to present, because I remember discussion about this trial before before the COVID and when they already started, because there are some patients who really don't want to go under the surgery, and maybe in really very well stratified or very well, let's say, characterize the tumors and the patient population, we can omit the surgery. But as you said, very carefully. And I would say we need more patients in this trial. We need more years of follow-up, because, you know, 3 years is not a lot on one hand, but in triple negative and HER2 positive, maybe it is quite enough. But I would definitely want to see more patients like that, and probably very, very, very detailed indications when we can go with not doing the surgery. And maybe I just remember during your talk that maybe we can also explain what PCR exactly means for our listeners. So
yeah, absolutely. So this means that at the time of surgery, if you take out the surgical specimen, so the neoadjuvant treatment, you have the cancer in the breast. You just do a core needle biopsy to have the diagnosis of invasive breast cancer, and then you place usually a clip into the tumor that you know where the tumor was. And then at the time of surgery, when the pathologist is not identifying any invasive cancer cells in the breast and or the ipsilateral lymph nodes, the sentinel lymph node, or whatever that has been provided at surgery, we call it a complete response. So DCIS is allowed in the breast, but no invasive cancer. And then if you just have the target, the clip in the breast, even if you don't see anything on the imaging, ultrasound, mammography, or MRI, whatever you do, then you go with the same core needle biopsy under ultrasound guidance or whatever, directly into this hot spot and take another, whatever, 5 to 10 core needle biopsies. And if you don't see any invasive cancer, and that is the cohort that has been tested here, then you assume that there is a pathologic complete response. And I fully agree that if you have a patient who, from whatever reason, is not accepting surgery, this could be an option, definitely. And I'm happy that they were going for whole breast irradiation and not only for localized treatment, because we all know that the recurrences are occurring in the index quadrant. But I mean, these patients have a very good prognosis, as you mentioned that, and I would not jeopardize this by techniques which are not ready for prime time.
Yeah, I agree. Yeah, thank you.
Okay, let's go on. And then we stick to triple negative breast cancer. And I picked here from the late breaking abstract 22, Peter Schmidt's Keynote 522 trial, which was actually changing our understanding of how to treat triple negative breast cancer and made us some experts in immune oncology. And we're going to see what's happening here in the update of the event-free survival from this phase 3 trial. So the combination of pembrolizumab as an immune oncology drug and chemotherapy is something which reminds all physicians to really know the history and the comorbidities of your patients, because these are very effective drugs, but they also introduce some kind of long-standing toxicity. So it's a balance of, getting a high result of PCRs and your personal learning curve of treatment-related side effects. So this is a cartoon of that trial, and I think everybody knows it. It is very simple. It's a randomization in the neoadjuvant therapy of carboplatin and paclitaxel, followed by docetaxel and cyclophosphamide. And in the green bar, it's pembrolizumab, and then the other one is placebo-controlled. And all these trials have the efficacy measure at the time of surgery, and then they have the adjuvant phase. That means after surgery, the maintenance of pembrolizumab for 27 weeks versus placebo. So based on the data, we now know that placebo-controlled trial in this setting are not ethical anymore, but this is a follow-up of these data. So what we've seen with a 60 months follow-up on event-free survival is, again, in red, that there is a benefit 81.3% of pembrolizumab event-free survival and 72.3% in the placebo arm. And what I've found very striking in this 5 years follow-up is 9.2% recurrence and distance recurrences on the pembro arm and 14.1% in the placebo arm. So as we have discussed neoadjuvant treatment extensively this morning, you're going to see that the PCR, the 5 years event-free survival for those in the PCR arm is 92.2% for the pembro cohort, and the placebo group is 88.2%. But interestingly enough, you're going to see that also in the non-PCR arm, pembrolizumab is obviously adding something. And I can read those tables, but I mostly want to see the pictures because it's much more impressive on that. So on the far left, every one of you might see that if you have a PCR, you just simply have there's almost no difference. So the chemotherapy is working and pembrolizumab is adding as well. But in the non-PCR, you have also and that has been never shown before, a benefit. You see 62.6% versus 52.3%, with a hazard ratio of 0.72. So the treatment benefit is 28% relative reduction in recurrences. And these data are very convincing to motivate our patients on the maintenance after their surgery. So the conclusion here is that we still should use these data as they have been tested in the trial. So these are patients with triple negative breast cancer bigger than 2 centimeters in size and or histology proven node positive status. Smaller tumors, node negative tumors, are not the subject for this kind of treatment because it has not been tested yet. And as I mentioned, the side effects in terms of patient safety have to be honored very strongly. And we have to wait on the overall survival data. And this is always a good sign that we do not have the overall survival data because the number of events are not in-house. So it's a convincing evidence to use it when it's appropriate. So that's what I want to discuss here.
Yes, I really agree, and I like this trial. And as you showed, there are also some side effects and of immunotherapy in this case with pembrolizumab. Can we learn also something from other cancer types, because this pembro is used in other cancers for more years than in breast? Can we maybe learn something from them about the side effects, about late side effects, and how this will affect the quality of life after the treatment?
I'm totally grateful for this question. So, if you walk in a doctor's shoes, get his new drug, you're highly motivated to use it. And I can recall my first 3 patients, and I've never seen so much toxicity. So we were asking ourselves, is this justified? And what we learned out of that, also from the cross-trial comparison of the toxicity, is to really talk to the patients, let them know, don't be over-motivated. And if you have elderly or patients with comorbidities on the GI tract, for example, on the liver or other disorders, be very cautious. So if you have a long-standing GI toxicity with constant diarrhea, and something I think we should not discuss this in depth, everybody understand that, or myelosuppression, which is affecting your life. We are monitoring these patients every cycle. We just talk to them, and they have to have a level of understanding. And in other words, we have to partner with them. I cannot offer this to someone who is not on a level to understand what the side effects is reported, coming back to our department. So these are very, very important learning points that we have walked through.
Again, I think that we can say that also with this design, is very important that we use this for patients who really need this and will benefit from it, not just all triple negative breast cancer patients to take. It sounds really nice, immunotherapy, as you said, very, very new treatment, but we really have to take care about it. Let's move on.
And as you just mentioned, that can we learn from other trials? This is something which is the other extreme. This is hormone receptor positive, HER2 negative early breast cancer. And Dr. Lawyer from Australia, who is always a pioneer of bringing in new ideas in the treatment, is now asking the question of if nivolumab, another represent of the immune oncology, versus placebo, is active in the neoadjuvant chemotherapy of adjuvant endocrine, or in the adjuvant endocrine therapy. So something which was completely out of bound years ago, because this is the domain of endocrine treatment. And let's see what she did. So the question here is, even if this is a prognostic, I would say a positive tumor, endocrine regulation works nicely with the new drugs. The question is if the checkpoint inhibitor nivolumab is working here. And it's a very complicated slide but we simplified it here. These are the patients, small tumors, node positive, grade 2, ER, and that is the interesting part here, even the low expressors, whatever measure you take, it's the neoadjuvant chemotherapy with nivolumab versus chemotherapy and placebo. And the primary endpoint in terms of efficacy is pathologic complete response, as you nicely alluded to in our previous discussion. and the usual ones: residual cancer burden, adverse events, and death incidences. What you're going to see here is the top line results in terms of the population. In the blue boxes, you're going to see the PCR, which is on the left side, about 24.5% versus 13.8%. And if you have a enrichment of the protein of Des ligand 1, which is in the immunohistochemistry staining larger than 1%, then you have 44.3%. So the basis of this trial is a proof of concept that obviously this drug is adding to the neoadjuvant treatment as a proof of principle. So we do not have data what would happen if you have more PD-L1 expression in your tumors, and this is an ongoing debate. But the take-home message here is that at the moment, for me, actually, it's a kind of an overtreatment, if I would put it in routine treatment, because maybe some of the people in the audience or the women who are just watching us are aware of what we do in Germany, this dynamic Ki-67 measurement to see if the tumor is endocrine sensitive, and then we decrease getting rid of chemotherapy. So this is another way of de-escalating this, but again, it's a proof of concept trial to bring that further. And as you mentioned earlier, maybe there are some patients who are benefiting from that. And again, here, very interesting data, and I encourage the investigators, and I'm grateful to those patients who are just participating in this trial.
Yes, really, as you said, interesting trial. I was really surprised when I first saw this. But maybe, do you think that in some patients, eventually, when we will get more results, we could avoid chemo and use just checkpoint inhibitors, or this is too far to say it now, or maybe in the future when we will have more?
So Tanja,
more data.
That's a fair question. When I was sitting on the patient's chair, and I'm confronted, so this is a cancer, these are the options, and would you jump out of the plane without a parachute to have a safe landing? I would be very, very cautious here. So, if you're just going to test that, it means that you have to have a neoadjuvant trial to see on efficacy, nivolumab versus nivolumab and chemotherapy. So it's just a single drug and endocrine, whatever. So it's going to take a number of patients, brave patients, to go for this. And I'm pretty sure if we have a biomarker which is predicting a positive outcome, that would be easier. But the breast cancer itself is getting in so small subgroups that I'm sure that this is something where we're going to hear, again, not on the bright scale, but it could be a very smart program to just see if the amplification of PD-L1 is important, something like that. And we know that Shireen Loy and others are just advocating the hot cancers being very immunogenic. And also the endocrine active ones could do it as a subgroup. And maybe these are the patients benefiting from that. So what everybody is saying here, stay tuned, wait for the further results. And to be very honest, everything was in the hand of these sophisticated trialist groups. They have a high level of adding to our routine treatment.
Yeah, I agree with you. And especially with this over-treatment, sometimes, when we try to get better outcomes, we tend to have maybe a little bit too much. That's why we need a balance on the both sides.
Exactly. And it's again, really picking the right patients.
Yeah, let's move on.
So let's go on in the same direction that you're going to see simply how many options we have. So we just picked here the data from Fatima Cardozo, who is really the definition of a patients-oriented oncologist, And she was presenting, again, a late-breaking abstract, what's going on in the neoadjuvant setting pembrolizumab or placebo plus chemotherapy, followed by adjuvant pembrolizumab plus endocrine treatment. So I don't want to puzzle our audience, but it's it's the same lines. We're triple negative, HER2 positive, and now we have the third group of the endocrine sensitive breast cancer being HER2 negative. And again, we are focused for pathologic complete response. And it's early high risk of recurrence breast cancer. So I avoid to talk about high risk cancer because it's a subgroup what's going on here. And again, that's a simplified cartoon what's going on here. And here the question is, if pembrolizumab is adding or is synergistic or additive in the treatment of endocrine treatment. Because in the triple negatives, due to the triple negativity, you don't have endocrine treatment. And the question here is there an additive mode of action in the post-neoadjuvant treatment? Okay. So the dual primary endpoints are PCR in the definition we are using and event-free survival. So it's efficacy until surgery, and then you're going to see the event-free survival in terms of long-term benefit. And this is a busy slide, but it shows you again, there's a follow-up of 33.2 months. It's a little bit early, but you're going to see that the PCR rate is a little bit different than what we saw in the triple negatives. It's 24.3%. And in the placebo arm, it's 15.6%. So it's the same range like the data from Dr. Loy we just enjoyed. Secondary PCR, the data, 10% difference. And treatment-related adverse events in the neoadjuvant phase is 52.5%. So almost every other patient had those side effects. And there was one myocardial infarction. If that was treatment-related or not, I cannot disclose at that point. Again, it is something which is bringing some new information. It is the question, who works with whom best from a drug perspective? And it's not something for everyone. So we in Europe have a different attitude on the endocrine treatment. We would like to decrease the amount of unnecessary chemotherapy, but as you mentioned it earlier, can we use immune oncology drugs or checkpoint inhibitors on its own? I don't have an answer on that. That needs some more time, but it is obviously working in the triple negatives and in the endocrine sensitive cancers. So that's my takeaway from that trial.
Thank you. Thank you very much for this nice overview. I could just say I agree with you, because when the treatment with pembro came into breast cancer, we were all excited about triple negative, but now we see that also in some part of hormone positive will also work. And again, in this trial, I can say that we see that how important it is to find those patients who will benefit from this and not just give them all everything. On one hand, we see de-escalation of the trial of the treatment, and on the other hand, we see, if we can use that word, escalation of the treatment, adding new therapies to all of this. I would also say, yes, that longer follow-up for this would be needed. But if we say in conclusion of all of this, our abstracts and presentations that you summarized for us today, what would be the most important thing for you to say to patients? Now we saw triple negative, HER2 positive tumors, hormone positive tumors. What can we learn from this year's ESMO Congress?
Well, that's a very good question. First of all, the most important thing is, and this is what I tell all my patients from a clinician side of view, that breast cancer is a serious disease, but in rare cases, it's an emergency case. So, nature took months and years to create this cancer, yeah? And then we should take at least a couple of days or maybe 2 weeks to have a good plan how to treat that cancer. And that needs these kind of treatments we inhaled this in this session here needs, even for me, time to consider which is the right way of doing it. And I you know, I'm not selling something. I just want to put the patient in the same boat where I'm sitting, to see that we are a little bit smarter than the cancer is. Sometimes we are happy to do it. And I really talk to them, even, you know, in the idea that I join those patients while they're on treatment. And even if they have a hard time, I just want to have the same level that it's justified to use it. Mm-hmm. You know, even in the checkpoint inhibitors, these patients need a lot of support to understand while they're on the flight that's a good end. And surgery is such an important day for those patients to see if all the efforts were just paying off. And I have so much respect for those patients who are saying, hey, doctor, you know, it is very nice what you know, but, you know, this is a little bit too hard for me. And then what I do is I ask other patients, fellow patients who are just walking through this treatment, that they are talking on their level. Because, you know, what I think is not what the patients think and what their ideas are. And I just give them a time of whatever, 14 to 21 days. In the background, we are just creating everything. But I just have some timelines, you know, I just want to have a decision, yes or no. Yes or no. And then if there are any doubts, I don't force them into that. And what we've seen so far, Tanja, is that if the patients are talking one-on-one, they have a totally different understanding on that. And when it comes to randomization, which is also still a big problem from a patient's end, you know, so doctor, you're the expert, and then you don't know it. You just make a lottery of my treatment. Then the only answer is, you know, if you go back in the 60s where mastectomy was the only option, and then the randomization brought us the option of breast conserving surgery, and the same thing is on sentinel lymph nodes. So these are the big puzzle pieces where the patients understand. And I mean, breast cancer is a very emotional issue, because the level of knowledge in our patients' minds are fed by Dr. Google and other colleagues, you know, who are uncontrolled, disseminating their data. And then you have to bring them back on track to have a plan. And that takes some time, and you have to be really, you have to roll the same or walk the same road like the patients, because you're just a guide for them, and that's it.
Yeah, I would totally agree with you. We need these trials to improve the outcomes, but on the other hand, we need a very careful communication. With your first two presentations, we showed how important it is to communicate, good communication between doctor and patient, and this goes through the whole procedure. I would say that I always, when I speak to new patients and when someone asks me, I always say, yeah, like you did, most of the breast cancers are not an emergency, and we can always take a few days to think things over and to take the best decision for ourselves. I'm really looking forward for this new trials, and I believe that someday we would be able to avoid more chemo, because we know how long-term effects of chemotherapies are. But also we have to be very careful with this immunotherapy, because there are also long-term side effects that people are living with, and that we can learn more and more, not just from breast cancer, but also from other cancer types. So at this point, I would like to thank you, Christian, for this really good selection of the abstracts, and for taking time to explain this to our listeners, mostly probably patients or patient advocates, or even general practitioners, as we learned from our previous recordings. And thank you also to patients today to support this kind of initiatives.